That's a good point. What causes pain? And I think that is a topic that's up for debate, believe it or not. So it's not like pain is not you touch a hot stove and you take your hand back. That's a reflex, which is also painful. But pain is a complex system where hundreds of thousands of signals are going up to the brain and hundreds of thousands of signals are coming down from the brain. So how do you know which one to pay attention to? If you're in the Final Four playing basketball and you sprain your ankle, you're not paying attention to that ankle sprain. You're on adrenaline. You have a goal. You're pushing past that pain. But the same signal is there. The same hot stove is there. So you're able to suppress pain. And so part of this is understanding that complex mechanism between signals going up and down your brain to help you deal with pain.
Hello, and welcome back to The Vitals, the Mount Sinai Health System's groundbreaking roundtable video podcast. I'm your host, Leslie Schlachter, a neurosurgery physician assistant here at the Mount Sinai Hospital. On this episode, we'll delve into a subject that most of us, unfortunately, can relate to, pain, and I am one of them. I'm joined by two Mount Sinai doctors in this field, pain management specialist Dr. Houman Danesh and neurosurgeon Dr. Tanvir Choudrhi. Gentlemen, welcome. We're here talking about pain. There's a million different reasons why people come to see you for pain, but generally people are coming to you for like spine pain, right?
Yep.
Okay. So hopefully the goal is to do non-invasive things first with a pain management doctor, and if they ultimately need surgery, they see a neurosurgeon, right?
That's correct.
All right. So what are like the most common reasons you see people for pain?
Most commonly neck pain, migraines, back pain, facial pain, and then slew of shoulder, knee, back, everything else too.
What's like the most common? Is it spine?
Yeah, it's mostly spine with headaches.
Okay.
Because your headaches can be coming from your spine.
Yeah, I did an Instagram post about that recently, that a lot of my patients that come in that have headaches, you know, they've had surgery, brain tumors or whatever. I'm like, I know you think your headache is related to that, but it's actually usually coming from the neck, and you usually can fix them.
Correct.
So what's like, how are you treating people? Is it with pills?
No, pills are very controversial, and we had an opioid epidemic because of them. They have their place, but there's a lot more understanding of what causes pain now. So what you want to do is actually assess and figure out what's going on and what the weakest link is, and then piece that puzzle together. So for example, if you have neck pain and you have weak rotator cuffs, those two are very closely related, mainly because when your rotator cuff is weak, your supporting musculature overworks, and the supporting musculature originates from the base of your neck over those cervical facets. Those are joints in your spine, in your cervical, upper cervical spine, and what they can do is radiate from the back of your neck to the top of your head, almost like a crown-like sensation. So patients will say, I have this headache, it goes like this, it's horrible, it's worse when I look up. That's a prime candidate that would benefit from a facet injection in their cervical spine.
So the lay person doesn't say, oh, I have headaches, maybe I should go see a pain management doctor for my neck. So how do they make their way over to you?
They call the office and they come on in.
Or do you get most referrals from the patient themselves, or is it usually like their primary care calling?
Primary care from surgeons, people trying to figure out, other doctors trying to figure out what the underlying cause is, and the MRI looks clean and they can't figure it out. Or just people calling based on that their friend saw me. Or
Emergency room, too. Sometimes if they don't need to stay in the ER, they'll send and have you follow up with you guys.
Yeah.
Yeah. So I see, as a PA, myself as well as a lot of other PAs, we see people with pain, right? So we're working it up. Sometimes we get x-rays, sometimes x-rays, MRIs, and CAT scans, but a lot of it can just be talking to the patient and doing a physical exam. How does somebody know whether they should come to someone like you for an evaluation, or if something's bad enough that they actually need to see a surgeon?
Great question. I'll defer the surgical question to him. But as far as whether or not they should get this worked up or start to see someone, most pain conditions resolve around 6 weeks. So if you have tolerable pain and you're like, okay, it's been a week, should I see someone? The general answer is the 4 to 6 week mark is when you should probably see someone. Now, if your pain is intolerable, you're miserable, you shouldn't wait that time at all, because there's no reason to be that uncomfortable in today's day and age. And as far as surgical, I'll defer to Dr. Choudrhi.
Yeah. So thankfully, a majority of the acute pain syndromes for the spine, neck or low back, resolve on their own. And so a lot of people are doing basic management, primary doctor. Sometimes they go to urgent care, maybe the ER. But for the people who have it persisting for X number of weeks, or if they have any red flag symptoms, and that's really what you have to focus on, is beyond pain, if there's any major neurologic deficit, a weakness, major numbness or tingling, or bowel and bladder problems, or really if there's other red flag symptoms like that could point to something else, if you have pain at rest or at night or with night sweats or with fevers or something that points to unusual presentation of an infection or tumor, then you need to get seen much sooner and right away. But aside from that, for the garden variety pain syndromes, really we have a system built on many different points of entry. But if they're persisting, then they need some help. They need something, either some imaging to figure out what's causing it, and then some sort of treatment. Hopefully, it can be managed without surgery. We want patients to get better without surgery, but many don't need, can't get better, and they need to see a surgeon. And in the end, what brings them to us is usually persistent pain or some that's refractory to the non-operative management or some type of neurologic deficit. And, every once in a while, the sequence goes the other direction where they come to see us because we treated their cousin or something, and they come to see us, and then we say, you need to start with the basics, and we send them over to him. And so that's really part of how the system should work.
Right. I've also it can actually happen the other way where the deficit comes first. I've seen patients and I've heard from friends where they have a foot drop. Their back hurt a little bit, but all of a sudden they have a foot drop, and that's typically an emergency, right?
Right. And that's the interesting thing. What you bring up is there are sometimes patients who are most bothered by their pain, and if their pain is not out of control, they're almost overly dismissive of it, and they could have weakness, numbness, or something else like that, or they're limping a bit or something, and if they can get by and if the pain's manageable, sometimes people push off too far, and that's really those type of things, weakness, numbness, foot drop, that's when you really need to make sure you're in the system. And we have a great collaborative relationship. Just recently, he had a patient who had some weakness, had a deficit, and he said, you have an MRI that's abnormal, you need to get in to see a surgeon. And, even though regular appointments take many weeks to get into, for those type of things, we all bend over backwards to get them in.
Right.
And I think it's an important point. You do want to have a primary care doctor, and most people don't. And if that's one thing people take away from this podcast is to have a relationship with a primary care doctor, that's probably the most important thing. Because we're talking about pain today, but we could be talking about any variety of conditions.
Right.
And when something happens, how do you know who to go see? How do you know who's reputable? And primary care doctors are known as gateway doctors, but they're almost like an internal Yelp review, because you may have a foot drop today, and that might be one factor, right? That you're one patient, 1 foot drop. But primary care doctors will see that 50 times a year, and they'll send them to different doctors and get to know, okay, well, patients are generally really happy with this and have good outcomes with this doctor. So if I get this call, I'm going to send to that doctor. Mm-hmm. So you are kind of shooting in the dark when you're in pain. Not a great time to start thinking about this.
Right.
So that's why you really need a good relationship. Do your yearly checkups, and then at least you're plugged in and know if you do have an emergency.
That's a really good point, because if somebody tries to get an appointment with a specialist on their own without a primary care, they could wait weeks or months. But if you have your primary do it, it could literally be next day or next week.
So they could expedite it. They could direct you the right way. And really, for patients, it's an investment in their health, because if you're mostly healthy and you're going by year, you're just getting your cholesterol checked, you don't think you need it so much, but really you do, because when things come up, it can be very quick, and you need to get into the system.
So let's just try and focus on, because back pain, neck and low back pain are the most common pains, right? What are some of the risk factors for that? Is it generally just heavy people, skinny people? How does it work?
With the easy one.
Okay.
Lack of sleep. So we know that a lack of your sleep is your body's way to regenerate. It's the foundation of physical, mental, and emotional health. The average recommended sleep time is 7 to 8 hours a night. Americans don't get that much sleep. So that is one major red flag for me and every single patient that I see. They get that whole entire talk, sleep. That's the most foundational important thing you can do. Mm-hmm. Then you have to layer on muscle imbalances. So what does that mean? If someone sits all day, they don't exercise, their muscles start to get weaker and weaker and weaker, and their supporting musculature gets weaker. Then they bend over to pick up a pacifier or a pencil or whatever.
Or and then take out the garbage or something.
And they herniate a disc. And they're like, well, why did I herniate a disc? I'm only 26 years old. It's like, well, when I examine you, you have absolutely no strength supporting your spine. Your glutes are almost unable to fire when I ask you to lift your leg up backwards. It's not a great sign. So you've just sat there and haven't done anything to help prevent that certain issue. And finally, something broke the camel's back. But it's really, really important to stay balanced musculoskeletally. And then there's also freak accidents that happen, too. But the things that are preventable are make sure you're activating your glutes, make sure you're strengthening your glutes, make sure you're rotating through a good hip range of motion, thoracic range of motion, make sure your shoulder rotator cuffs are strong, and help combat having a sedentary lifestyle.
So sleep and exercise.
Sleep and exercise.
And I would build on that. I think those are foundations. I think what you alluded to earlier, weight is very important because your spine is only built to handle a certain amount of weight.
Right.
And when you get far above that, a couple standard deviations above the normal, it makes it very hard. And you may tolerate it for a while, but after a certain number of years, it just takes its toll. The other thing that's very important is smoking. They've done studies to show that the discs don't have great blood supply. And so the small blood vessels have to permeate the oxygen into the disc. And they've done studies on animals showing that if they have nicotine in cigarettes for 12 weeks, they really have more accelerated degeneration. And so it really makes a difference. So these are all the things, and just exercise and, all the basics that we sometimes take for granted, but, hydration, exercise, eating well, all those things overall lead to better weight and leads to better spine health.
What has like the upswing in sports like CrossFit and things, what has that done for people with injuries and pain and needing surgery?
Well, paddle, or what's the other
Padel, paddle,
Yeah.
all of that. Yeah.
Increase in eye injuries and orbital fractures and retinal detachments. People that, again, are not active for a long period of time, then they play flag football and they tear an ACL, Achilles, really, really common. I think if you are going to do any sort of activity, you want to make sure you build your base and foundation first. And most people don't have the time nor think to do that.
So I think it's okay just to play sports one time a week.
Or after not having played for 10 years, getting together with some friends and deciding to play
Yeah.
a sport, start and stop, which your body hasn't done in decades.
Right.
And
Like
something
the
will
once a
go.
year softball tournament.
Yeah.
It's a big one.
Yeah, that's true.
I think part of it too is we always talk about exercise to stay healthy, but how do you know what type of exercise? And there's always information coming through. Do you do zone 2 cardio? Do you walk? Do you run? Do you do jumping jacks? Do you squat? Do you do weightlifting? And I think that's part of the difficulty of navigating what the proper exercise is. And I think it's important to understand how your body's made up so you know what kind of exercise to do. For example, if you are someone that has very little flexibility and lots of muscle mass, your exercise routine should include mobility exercises, which is not just passively stretching, it's actually working in your end range of motion with weights. If you're someone that's hyperflexible or hypermobile, and people say, oh, I'm double jointed, those patients really have to focus on stability exercises, which can involve weight training, but if you weight train and you're hypermobile, you're more likely to get injured. So you
Right.
have to work up to the weight training. And I think that's the hard part is most people don't talk about it, most people don't know. And there's exercises that are good for your heart and your longevity and increasing your VO2 max so you can age and increase your health span. That's very important. And then there's exercise to decrease injury, so injury prevention, which depends on your body type. So how do you know? You should probably get assessed by a physiatrist or a physician that knows how to work up hypermobility, very important. And then see what your hip range of motion is like, see what your shoulder range of motion is like, see what your strength is like, and then come up with a proper exercise program.
Do you
for
see more patients that are in pain or injured from inactivity or improper activity?
I get asked this all the time. I think the evidence has been all over the place. It depends where you want to look at it, at what point of injury and what point of lifespan. But essentially, exercise is much preferred over bed rest. Controversial and debatable. One of the lead authors on multiple studies that show bed rest should only be for one day. He happens to have some conflict of interest, which makes that debatable. But I think, in general, the more active you are, the better.
Yeah. What about you? Are most of the people having surgery, is it just chronic pain?
Yeah, I think you see both ends of the spectrum. More commonly, it's people who aren't doing any work and are sedentary, not taking care of their core, not taking care of their neck muscles. And the other extreme, the weekend warriors, we sometimes see as well. And those people tend to, first of all, many of them can avoid surgery. They have something, but then they recover without it. Or if they do need surgery, they get back to life pretty quickly.
Yeah, because they put in the work.
They put in the work. So really, that is the end to be err on. But what we're really saying is it's great to be active. Just do the foundational work and don't just be episodically active. Like you could, maybe when you're 20, you can do all these things. You can go and play flag football or do something after not doing anything for 2 months, 3 months. When you get older, you have to invest in it. And it's really,
Right.
that's the key.
I'm a good example of someone who kind of went through all of this. I had severe back pain for many years. I'm 6'4", weigh over 200 pounds. When I was playing basketball, I was 225, 230. I was a big girl pounding on my body, and I hurt my back. Herniated discs. I got, very damaged lower back. And I spent years going through injections in PT, and I did everything that I was told to do. I worked with, pain, and there was like cortisol injections, radio frequency ablations. I did everything. And then when that stopped working, I had spinal fusion, a 2-level spinal fusion where they went from the front into the back. So how, for someone out there, whether it's their neck or their back, what's like a typical trajectory? Is it like just do your best by yourself, then maybe injections, and then physical therapy, and then if it persists, surgery, or have things changed in the last couple of years? And this is assuming there's no neurologic deficits that need surgery immediately. Right.
Assuming that's the case, then you do want to go through a long progression of things. The first thing I'll say, though, is you represent a subset of people who are the elite athletes. And the people who are elite athletes, they've done studies because they're very studied. Like the top gymnasts and the top others, they've done lots of studies. They've shown that sometimes they had little injuries when they're in their late teens or 20s and stuff, and they get over it. But when they get to 40 and beyond,
you pay the price.
They pay the price. And so it's kind of accelerated aging. What could have happened 30, 40 years later gets pulled forward. So that's a separate subgroup. But I think really what we're getting at is when things start to go off and you start to feel like I'm just not right, the biggest mistake is people just say, I will stop doing X.
Right.
I stop just running, or I stop playing soccer, or I stop playing tennis. And while it may work, that's not really the solution that gets you to where you want to be, because you want to be that person at 75 playing tennis. You want to be that person who's still skiing or going for a run. And so I think that gets back to the foundation of where you started at the beginning. So
Yeah, I'm really glad he said that. It's so true. Patients will start having pain in their 30s, 20s, and stop doing that activity, and then they'll see me in their 40s and 50s. And now they have to stop doing something else too.
Yeah.
Meanwhile, again, their muscles just aren't firing. They're not protecting their body, and that's what's just continuing to degrade as they ignore it more and more, or as they restrict their life more and more. As far as what do you do first, it depends. So if you know that putting a hot pack on your neck helps your pain, and you use it once a week and doesn't affect your life at all, otherwise you can keep doing that. But I think the sooner you get an evaluation of the muscle imbalances that you might have, whether by a physiatrist, a physical therapist, a primary care doctor, the sooner you know the exercises to help you progress through the decades of life with less issues, the better.
And then you actually have to do them.
Of course you have to do them. And you can't only do them when you go to physical therapy.
Right.
I mean, I think the most common question that I ask is when patients say, I haven't seen them in years, and they come back in with the same issue, first question is, have you been doing your exercises? And they look at me and they say no. So the answer is easy. You know the exercises.
Compliance is low on them. They're not as fun as some of the other things. People like to go play tennis or basketball, whatever. That's it's a little more of an investment, but I want to give a cautionary tale. Now, due to better cancer care and better heart care, people are living longer.
Right.
So now we're getting people living active lives into their 80s and 90s. And so what really matters is the muscle investment you make along the way, as well as you get older, strength training and other things that people think it's just the younger people. That's not true.
Right.
You need to do more as you get older, because we're running into an epidemic of people who have some spinal alignment issues, scoliosis and other things. And some of that's really preventable. A lot of it, I mean, there's one type of scoliosis, which are people in their teenage years and young adults. But really, there's a whole adult idiopathic scoliosis. It's very big problem. And, it's one thing to have a disc herniation or a stenosis that needs a small surgery. But once you start needing the bigger things and corrections and alignment,
Right.
it's a cycle you don't want to get into. And so really the best way is to prevent it.
Is that from everyone using their devices now? Is that
There's
a
a
device
bit of that.
problem?
That's not the only problem, but there's a bit of that with the neck. And,
What is the uptick, or why are people more likely to have spinal deformities now?
I think people are just living longer. It used to be that people worked a lot of jobs that are very physical in factories. Now we've moved into intellectual work.
Right.
A lot of desk jobs, sitting.
We watch AI work for us.
There you go.
Yeah.
So these are all factors.
Mm-hmm. And then let's talk about injections, because I bought myself years from injections. How do injections actually work?
Depends what the underlying issue is. So sometimes injections will work for a herniated disc by reducing the inflammation.
So
That's
like a
one way.
cortisol injection.
Cortisol injection, just a washing away all the chemical irritants that come out of a herniated disc. So that's one way. Another way is it actually turns off the nerves that are causing the pain with a radiofrequency ablation, where then the pain is gone for a period of time until the nerve actually regrows. So it's almost like a starfish, and it's weird because we think that you lose something in your body, it's not going to regrow, but these nerves up and down your spine actually do.
Right.
So that's something very important to remember. And I think ultimately it's what you have to think about is you need to maintain your body. So you're either going to apply stability by increasing your muscle strength. When we've danced around this a lot, skin is an organ. People will put lather on lotion on their face for 10 minutes a night, all different SPFs. But they forget that muscles are also an organ. And it can prevent hip fractures because the more muscle mass you have, you're not going to break a hip. It is becoming more and more aware, and people are becoming more active, and they're understanding the importance of maintaining muscle mass. And again, you have to be careful. And if you're double jointed or hypermobile, you don't necessarily want to weightlift. You want to use resistance training. It's not the same thing until you build up to resistance training. And then people that don't have the range of motion, they have to focus on mobility to help prevent injuries and hip replacements and shoulder replacements and whatever have you. So we focus on muscle stability. We do these injections to buy you time and to give you the quality of life so that you can do more physical therapy, and so to prevent the cycle. And
so like the goal is to be able to do physical therapy. Like 100%. The goal is to be able to exercise and move.
To exercise. Once you learn the exercises, then you do them. You don't necessarily have to go to a physical therapist, but you have to understand your body, know the exercises for your body, and progress them through your life. You shouldn't be doing the same exercise every single day for 6 months to a year. That's You're not putting stress on your body.
What do you do for people that just want surgery as a fix? They don't want to put in the work.
You know,
aside from the people with a neurologic deficit.
Unless there's a neurologic deficit, you don't want the quick fix. You really want to do it the right way. You want to try and avoid surgery, because even if you have surgery, if you don't do the investment to get your core strong and do all the things that are going to be needed, you'll be right back having another surgery and so forth. And so we really don't want to go down that route. And surgery helps a lot of people who have done all the right steps and they still need something. But if you're trying to do a quick fix to surgery, it's a big mistake.
Yeah. So it's not spine related, but I've been dealing with left knee pain for a long time. I'm actually scheduled to have a partial knee replacement in January. And I've been doing injections, and I do all the things for years and years. And I did exactly like you were saying before. 10 years ago, I gave up playing basketball. And then 8 years ago, I gave up running. And the number one thing I love to do in life is lift weights. And in the last several weeks or so, I literally cannot lift my lower body. And so I'm like, that's like time to go. Like, I know it's time to do this now because I can't do that anymore. I feel lucky that I prioritize exercise, and I know I'm going to do my best to get ready for surgery, and I know I'm going to do my best to recover from surgery. And I explain that to my patients too. Like, you have to be in really good shape.
Yeah, that's the whole concept of pre-surgical rehab or prehab.
Yeah, prehab.
You know? Yeah, it's very important.
I tell my patients...
There's studies to show it makes a difference.
Yeah, you have to live your life as if you'll need surgery, because you don't ever want to be in a scenario where your surgeon or doctor looks at you like, oh, no, I don't know how they're going to do. So how do you explain that to people? Like, their future life depends on how much effort they put in.
I think some people do have a longitudinal perspective of how they want to live their life, but a lot of people are just getting by as they go. And, I think educational forums, things like this, talking to people, I've done radio shows, I've done other things, we don't want, as surgeons and even people doing injections, we don't want more business in that way. We'd love people to be healthier and not need our procedures. But unfortunately, there's still going to be people who do, despite doing everything right. So I don't think people should view this as if they end up needing an injection or surgery, they did things wrong. You just got to optimize yourself. We all have different genetics. He mentioned the hypermobility syndromes that we're learning more about. There's a whole spectrum of things. We have named diagnoses for a couple things, but there's so many things. Even if you have Parkinson's, your muscles are different. If you have MS, you're the thing. So we work in a big center which has so many patients with these other disorders. So really, we become very adept at picking up how to manage those. And nothing beats getting ahead of it from the beginning. And even if you do have a problem, it's not a time to just say the injection or the surgery will be the end-all and be-all.
Right.
You really have to do the work alongside of it.
Yeah, and it depends on the type of surgery, too. And sometimes when you get surgery, the surgery will last 5, 7, 10 years, and then you need another surgery. So if you don't put in the work, you are going to be back doing something else, whether it's in another injection or another surgery, because we can't change the way the load of your weight against gravity is going to affect you throughout time.
If you have a patient and you think that maybe their lifestyle, like let's say they're very overweight, how do you broach that with someone? Like you can do everything for them, but unless they start helping themselves, how do you have that conversation?
Timing is really important, right? So if someone's in severe pain and they're overweight, you can't tell them to start working out.
Right.
They can't. And you can scold them and make them feel horrible for being overweight, and it won't go anywhere. Or you can help them get out of pain in whatever method and follow up with them and then say, all right, this is an opportunity now that you are feeling good to lose 5 pounds. 5 pounds of weight on your body is 20 pounds off your knees. So I'm not asking you to do some miraculous
5 pounds of weight off
Yeah.
your body is 20 pounds off your knees.
Yep.
I need that to make sense to me.
Force, right? So it's gravitational force, the way force of weight goes up against gravity. So if
Okay.
you just lose 5 pounds, it's 20 pounds off of your knees, 1 pound to 4.
Okay.
So it's
I'm saying
equivalent of
okay. I don't get it, but okay. All right.
The stress on the joint.
the stress
Yeah.
on. So
Okay.
so if you're holding a 5 pound weight in your arm and you're doing a squat, your knee is feeling 20 pounds of pressure.
Okay, got it. Yes, I understand.
Yeah.
Yeah.
So
I just made that make sense like when I do like that machine at the gym where you go up and down with the back, where I hold the weight, it makes it more difficult. So I understand that now. Okay.
Yes.
So you have to wait until they're out of pain. And then say, hey, this is
Pun
also a
on the word
problem.
weight. I think, yeah, it's about building a connection with the patient, finding out where they are. I had one patient who swore that she didn't eat anything and she has no idea how she's morbidly obese.
Maybe she has Cushing's disease.
She wasn't counting the Coke, liquid calories.
Oh,
So she
yeah.
wasn't eating anything, but she was drinking her calories all day, every single day. And, you know, it's hard to, like, keep delving in and spending time and figuring out, okay, well, how are you this overweight if you don't eat anything? And someone was in the room vouching that she doesn't eat anything.
Yeah.
Yeah, the weight is a very important topic. I mean, I think the Western diet has not been great. The Western kind of food industrial complex has made things a certain type, and I think that we have a higher BMI in America than in many other countries because we have more resources, and people have more technology that's helping to do things for them. And it's actually, they've done studies to show people who live in multi-story dwellings actually live longer because they're actually being forced to do the work.
Right.
Now, regarding weight specifically, it is very hard for some of these patients who get in a vicious cycle where they have pain that limits their ability to walk to lose weight. And then you almost fall behind the 8 ball because you can't exercise. You can't exercise because of your symptoms, and you cannot lose the weight just by caloric restriction. And you have to be able to exercise. So that's where sometimes injections play a role. You get them out of just enough pain that they can lose the 5 pounds, and then they can go beyond it. And now, thankfully, there's a lot of excitement and also caution with all the medications that can
Right.
be on, the GLP-1s and all
I
the
think
things.
I've seen a huge difference in my practice. I mean, I have patients who we follow a lot of patients for aneurysms and tumors or things where we say, I need you to get in the best shape possible because you might need surgery next year when we see you. And I have so many patients on GLP-1s and they're just shedding weight. I've seen a huge difference. Have you seen that in your pain practice?
Yes, and when you're overweight, it's really important, of course. And I think what's happening is a lot of people that are mildly overweight are going on these drugs. And
Yeah,
just
and then they're
remember-
losing muscle.
Exactly.
Yeah.
Weight is not just all fat. And if you lose muscle mass, you're almost compounding the problem that we've been
Right.
talking about, especially as you get older and are more sedentary. So it's really important to counsel patients to maintain weight training as they're losing the weight, to maintain as much muscle mass, eat enough protein even though they won't have the appetite.
Right.
So it's tricky, but it's a very useful tool and it helps a lot of people.
Yeah, I don't think people get that about these medications.
They don't. They look at the number
it's
of the
better
weight.
to be 20 pounds
and they look-
overweight with muscle than be 20
Right.
pounds underweight with none.
People are just focused on either the number or what their profile is, not
Right.
what the composition is. Your spine health and your muscle health is way more important.
What about things like bone density? Does that contribute to pain at all?
You know, we have, as people are living longer, we have a lot more people who are living into the years where unless they do something, whether it's with, diet, calcium, vitamin D, all the basics, and sometimes they have metabolic processes that need other medications to help their bone density because we're running into people who start having compression fractures because now we have so many patients living in their 80s and 90s who are walking, which is fantastic. but then they have falls.
Yeah.
And number one thing that really turns somebody's life south when they're in their later decades is when they have a fall.
Yeah.
And they break a hip or they have a spinal compression fracture. And so, yes, the key is to try and for men and women, it's more common in women, but men also need to be careful about their bone density. So,
Which muscles also help with.
all that's all tied together. It's all
So
connected.
basically, pain comes down to muscles.
Not quite.
Strong,
So-
mobile, but not too mobile.
That's a good point. What causes pain? And I think that is a topic that's up for debate, believe it or not. So it's not like pain is not you touch a hot stove and you take your hand back. That's a reflex, which is also painful. But pain is a complex system where hundreds of thousands of signals are going up to the brain and hundreds of thousands of signals are coming down from the brain. So how do you know which one to pay attention to? If you're in the Final Four playing basketball and you sprain your ankle, you're not paying attention to that ankle sprain. You're on adrenaline. You have a goal. You're pushing past that pain. But the same signal is there. The same hot stove is there. So you're able to suppress pain. And so part of this is understanding that complex mechanism between signals going up and down your brain to help you deal with pain. And part of that is behavioral modification, psychological assessment. People will say, oh, I can't bend over to tie my shoe, but if you put them on their back, they can bring their knee to their chest and tie their shoe. So it's some of it's learned behavior. So it's a very complex thing that we deal with pain and pain management, and you have to learn to navigate and understand what's actually the underlying cause.
And chronic pain has a whole cognitive overlay that's very complex. But I think pain itself, we have to remember, it's not the disease itself, it's a symptom. There's other things that are causing it. Pain is actually evolutionarily adaptive and actually protective. And so what you really should do is, if you're in pain, what is causing it? Your body's trying to tell you something, which is why medications aren't the best thing. If you just snow yourself and cover the pain, you're not really getting to the root of the problem. And that's really what we're trying to talk about here.
Is there any cool new technologies that help people? It could, now what we've talked about, maybe holding posture. Is there anything new wearables out there that help?
Ooh, you did the wearables.
I did.
All right, so the wearables are an annoying signal that keeps telling you you're in poor posture and for you to do this, for example. The problem is not the signal. The problem is you have tight pecs, which start from your chest and go to your shoulder. And when those get tight, your shoulder comes forward. When your shoulder comes forward, you're pointing down further and further. And now the only way to look straight is to look up. So the wearable will tell you to keep doing this, but is it going to address the underlying tight pec muscle, which goes from here? Is it going to address the weak rotator cuff muscles that are putting your shoulder in the right place? No. All it's going to do is keep making you do this. And so you need to, posture should be a thing of muscle balance. It shouldn't be something that you have to think about. So focusing on the rotator cuffs will fix that. So as far as new technology, which was the other part of the question, there's always new technology coming out and new devices and new this and new that. And I think a lot of them are promising the world, and you have to take that with a grain of salt. And some of them flare out after 3 years. And so they're very hot. They come in, everyone's like, ooh, I want to try this new procedure or this new surgery or this new whatever. And it's like, yeah, it's only been out for 6 months or a year. I'm a little hesitant to go there because the foundation is still the foundation. And what I'm telling you now about hypermobility and muscle being an organ, quote unquote, and dedicating time to it, that's actually the new thing. It's just not fancy.
Right.
And so it requires
maybe
work.
A desk that rises up and then a little treadmill underneath it. That's a good technology because you get moving and you're using your muscles.
Standing desks are interesting. They actually tax your calves even though they release your back. So people will end up with calf pain and calf cramps and have horrible pain in their calves and they don't understand why. Then you ask, when did you get your standing desk? Oh, right around the same time. Or when did you try these new shoes that barely fit on your foot and you can see your feet coming out of the edges and you can't deal with that.
That's actually one of the things that you like to talk about the most is shoes, because a lot of people end up in pain because they're wearing either the wrong shoes or they need to get new shoes, right? They wear their shoes the wrong way.
People definitely wear through their shoes and they don't realize it because they never look. And New York is tough because people don't drive, so the analogy doesn't work. But if you wouldn't drive in the tread that's left on your shoe, do not walk in it.
Yeah.
People will have wedges where it's like half of it's gone on one side, and what that'll do is just put pressure up the kinetic chain in an awkward way. People will sit on wallets and just sit like this while they're on a microphone, and they wonder why they get back pain. But you have to kind of just look at the whole thing. So shoes is a big one, and some people end up with really flat feet. Now, is the feet truly getting flat, or do they have a weak musculature up at the glute area by their lower back, and that's getting weaker, and therefore the whole femur is rotating and the whole leg is rotating
Everything
down?
comes back to the glutes for him.
The root of all evil.
Yeah.
But
What about in neurosurgery? Any new
I
technologies
think that
helping?
the summary is there's no magic pill or magic technology that's going to solve everything. On the other hand, I do think that there's value in technology being used the right way. I think even something simple as people monitoring their steps, or there are some things looking at balance and other things. And so we are trying to find ways to screen to get people into the system earlier, because sometimes problems are best treated before they get really advanced. People who have balance issues, you don't want to wait till they're in terrible shape, or the people who have lost their bowel and bladder function, other things. Regarding surgery, there's a whole lot of technology to make surgery safer, better tools, better things, better image guidance. And so it's interesting. Modern surgery has more monitoring, more tools, more technology. It's not always faster. It's actually a little slower.
It can take time to use all that stuff.
Safer surgery is sometimes a little slower in some ways, but certainly, thankfully, we've made major progress over the last few decades in surgery. Smaller incisions, smaller hospitalizations, better use without as much medication, and less blood loss and less complications. So I think that direction is good. The best thing is to avoid it, but if you do need it, at least now it's generally speaking can be done safer.
So I think for the people listening or watching, if you have pain, doesn't matter where it is, primary care is a wonderful place to start, and that could be your family practice doctor, internal medicine, primary care, MD, PA, nurse practitioner, doesn't matter. But also if you get into a specialist, especially at a place like this, if you see a neurosurgeon first and you're not a candidate, you'll get him to pain.
Yeah,
and vice versa.
You just
for
need to get into
needed.
the system.
You just need to get in.
We all work together and can redirect. I will say one thing. I'm a big believer in people having a primary care doctor and utilizing it. But they also have to remember they have to take some agency in this, because the primary care doctor has so many patients, so many things. If you're not telling them that the pain is still persisting or is affecting your job, or you've given up your sport for 3 months, you may not see them for another 3 months. So at some point, you've got to tell them that I think I need to see something more. How do I get into the system, as opposed to just waiting for them to manage the whole thing?
Right. Like here at Mount Sinai, you can, if you have a doctor and you MyChart them, you send them a message saying hey, this has been going on. You don't even need to go in sometimes. They'll just put in a referral for you to go see someone as long as they know you.
They're used to what the next steps are, and you just have to identify that you're ready for the next step.
Yeah. So I think what we learned today is sleep, exercise, be mobile, build your muscles, keep your muscles strong, but also mobile, and see your primary care.
And you left one big thing out.
Sleep.
Imaging.
Imaging.
When to get imaging, how to interpret imaging. I have patients that I'll see that say, oh, I have a herniated disc 10 years ago in my back. I'm like, and you think it's still there?
Yeah, you have to update an imaging.
And so, herniated discs heal. We don't talk about that. There's a lot of counseling when it goes into that. So how do you make sense of an MRI or an X-ray? And the question is, you have to put the whole piece together. Right. Imaging is a sentence in the story. It's not the whole story. And so you have to piece it together, and you have to take it with a grain of salt. Patients will say, I herniated my disc in 2003. I can't believe that's now 22 years ago. Almost 20.
Yeah, but it might be gone by now.
But the herniated disc may have resolved. You may have back pain, but it's probably not from your herniated disc. You don't cut your finger cooking in 2003 and come and tell the doctor, I cut my finger in 2003 and I never cooked again. Right? So yes, people have herniated discs. That could be normal. If you don't have pain from it, and that's the key, you have to assess what is the pain generator. So it's not always the disc. It's not always the joint. It's not always the spine. Sometimes it's the shoe. Sometimes it's the knee. Sometimes it's the hip that's causing back pain. And you could do the same thing for the neck. It's about putting the whole picture together, getting the images, making sure everything matches together. And then when do you get images? Some patients will come and go, I want an MRI. Like, well, an MRI will look at soft tissue, and your issue is most likely bony, so we probably need an X-ray or a CAT scan.
Right.
So it is kind of like knowing and navigating the imaging world as well. Imaging.
What would you say are like some examples of like biggest, because patients have access to Dr. Google now and ChatGPT. What's like the biggest example of misinformation that you guys could give?
Well, I would just say in my profession where we're dealing with major decisions on whether or not to do surgery, which is a very binary decision, right? And a big decision. The imaging results on the pictures in the reports, as much as, and my brother's a radiologist, and I have a great respect, but the reports are not everything. The details on the picture, and they have 400 images on an MRI. And it's like everyone looks at a painting a little differently. So there's different qualifications, the words, what's mild, what's moderate. So sometimes you have a patient come in, they're like, oh my goodness, my spines must be falling apart because I have this report. And we have to give it into context. And sometimes the opposite, where they're like, well, it only says mild to moderate, and yet they're like, my foot is weak and I can't lift it. And so really, I think what I would say is you need to rely on the experts, and you need the experts, and we certainly have them here at Mount Sinai in all the disciplines. And, we all have our areas of expertise. And so I would say the major area of the things are, one is the imaging, and then the other area of misinformation is, I think, we're so prone to anecdotal evidence influencing us. You had a cousin who had a neck surgery, and it either went fantastic, but the condition was different, or it didn't go so well, but your condition is different.
Don't do that surgery because it didn't work for my cousin's brother's daughter.
You read on the internet, and the people who are back to playing tennis or golf or basketball, they're not on the internet writing about themselves. So sometimes you go and you can, whether it's a medication, injection, or a surgery, you can kind of get a little bit of a skewed perspective because you're not getting the overall averages. And that's why you need honest professionals who have experience to help guide you.
Yeah, and you can get second opinions.
For sure.
That's okay.
Yeah, and misinformation has been dubbed fake news by some. And, it's rampant, especially on social media. There are people that are doctors that are really like doctors of nutrition talking about how to lift weights. And it's like your specialty it's very different than what you're talking about. It's hard because you get inundated. You go on TikTok, Instagram, Facebook, whatever variation is coming out, and there's so much information that's thrown at you. Back fusions. Oh, my cousin got a back fusion and it didn't help. It helps no one. That's not true. You have to be the right candidate. Another one is you can only have 3 injections and then you need surgery, or you can only have 3 injections and then you're going to be doomed to a life of osteoporosis and hair loss. Also not true. Right. It depends. You have to take each situation into account. If you're 95 years old and you can't have surgery and you get 2 or 3 steroid injections every year, that's probably better than just suffering, but you have to understand the risks of osteoporosis at that point, and you just have to talk to patients. And there's so many things that'll just skew patients one way or another, and it's always surprising. Or like
it's usually like somebody they know that had something that's usually
it's natural. I mean, I don't fault it, but you have to just understand that could lead you down a road that's
another thing I want to add that you guys just reminded me of is, especially in the world of spine, since we're kind of talking about spine, and I had this with my knee too, is sometimes not one surgery is the only answer. So in spine surgery, and we had this in our meeting this morning, Dr. A might be really good at one approach, Dr. B might be really good at a different approach, and both approaches might be great. So if you go see 2 different doctors and they give you 2 different opinions, those both might be right, because certain doctors are better at doing things a different way, and that's okay.
Yeah. So evolving from the misinformation diagnosis to now confusing information. And I think that is true. And it's very hard for patients because we did talk about the value of additional opinions, but sometimes it confuses the issue. You can see 5 surgeons, and there are multiple right answers. And it could be that for this one patient, that multiple things could work. And then you have to know as a surgeon your strengths and limitations.
Right.
If I've done 1,000 of this one and only 50 of the other one, and I'm so confident with my results there, even if somebody else has 1,000 the other direction and they prefer that, there's different reasons. And I think we always have to be honest with ourselves, honest with our results, and honest with our patients, and realize that there's not one simple answer, and we don't know it all. We're always learning, and we're always evolving because technology is changing, our experience changes, and I think that it makes it hard as patients, but it is helpful when you go to a system. And I think patients are savvy. They can tell, they shouldn't be sold on a surgery or an injection. You're coming to them for a need, and we're trying to provide the need, but it's really the patient who's choosing.
Right. Yeah, I think that's important because if you're a patient and you're listening to this and you've gotten 3 opinions, they're all different, but they're all from trusted sources, it's okay to pick, the doctor you liked the most or, the one that you perceive to be more comfortable with recovery.
There's
That's
any
okay.
number of reasons. People pick based on convenience, how close it is, what their insurance is.
If there's no parking in that garage.
Things. There's a million reasons. And, it's all a system.
Yeah.
We're all working together, even at different institutions.
Yeah, I say parking because my dad chooses his doctors on wherever there's free parking. Anything else that you guys want to add today?
I think it's important for people who are in pain to seek experts and not to suffer.
Right.
I think you covered a lot of great topics, and people should listen to this podcast over and over and over and like and subscribe.
Thanks for joining, guys.
Thank you.
That's all for this episode of The Vitals. I'm your host, Leslie Schlachter. Subscribe to The Vitals and Mount Sinai Health System's other video podcast programming on YouTube, Apple Podcasts, Spotify, or wherever you get your podcasts. To learn more about Mount Sinai's work in the field of pain management, scan the QR code on your screen or click the link in the description below.